data we presented was update of our long-standing active surveillance cohort. And this was an analysis of the 30 patients in that cohort who were initially managed with active surveillance and went on to be reclassified in most cases higher risk disease and ultimately treated, but subsequently failed and developed metastatic disease. So we looked at what factors predicted for the development of metastasis. Our cohort consists of about 1,000 patients, of whom 21% were intermediate risk at diagnosis, either because of small amounts of Gleason 4 or a PSA above 10. And I should just emphasize that although they were intermediate risk, they were at the favorable end of the intermediate risk and therefore seemed reasonable to offer them surveillance. We had an inclusive approach to surveillance for most of the period of the study. And what we found was that the major predictors for progression of metastatic disease were, of course, risk, but that the patients who were intermediate risk had almost a 4-fold greater risk of progression of metastatic disease than the low-risk patients. Further, amongst the intermediate risk, it was only Gleason score and not the PSA level that was a predictor for progression to metastasis. In other words, a PSA above 10 actually made no difference. Those patients were not at increased risk of ultimately developing metastasis. But the patients who had Gleason 4 on the original diagnosis, even if it was a relatively small amount, had a much greater risk of progression to metastatic disease. We've taken that information quite seriously. We've actually become somewhat more restrictive about offering surveillance in patients with Gleason 7, particularly to younger men. I still think it's very appropriate for selected older men with Gleason 7, particularly if it's a small percentage of Gleason 4. And in fact, we definitely offer surveillance to patients who have Gleason 6 but a PSA above 10. I think the importance of this study is that ours is a very mature active surveillance cohort, and we are really the only ones who've had any significant number of metastatic events or prostate cancer mortality. And I think the message is quite clear that some caution is warranted in patients with Gleason 7 cancer. And I think this is where MRI and biomarkers are going to have a role, because there are undoubtedly some patients at the favorable end of the Gleason 7 spectrum who are candidates for surveillance.